Good morning. Good morning, everyone from Hong Kong and from the Asia-Pacific region, and greetings from Hong Kong to the rest of the world. I'm Dr. Robin Chen, the Vice President of Hong Kong Cash. On behalf of the Organizing Committee of AP Cash 2022, I'd like to express our warm welcome to all participants, either physically at the conference hall or virtually online. This year, we are very, very excited and happy to be able to reintroduce our live cases, which is one of our hallmark of the AP Cash. And we are very honored to have excellent centers to participate in the live cases. And this morning, we are going to concentrate on congenital and pediatric interventions. So we are excited to have National Taiwan University team from Professor Joko Wang to deliver to us the live cases. So I'm going to introduce our co-moderator this morning. We have Dr. P.C. Chow from Hong Kong and Dr. Warren Pham from Thailand. Good morning and thank you both. And we also have excellent panelists discussing this morning, Dr. Jimin Kim from Seoul National University Children's Hospital from Korea, and also Dr. Jenning Wang from National Cheng Kung University Hospital, Taiwan. So without further ado, this morning we have a very early start in Taiwan, so we're going to move to the live cases first. So I'll pass the session to National Taiwan University, Professor Joko Wang, please. So we're still waiting for the signal to switch over to the live center at National Taiwan University. Bye. So I believe we are still waiting for the signal. So this morning we have the first case is should be a pulmonary valve case, and we'll see when we'll be ready. So otherwise, this morning our sessions will concentrate on VSD occlusions, and we'll have two sessions. This morning, the first session will be lectures from experts from the Asia-Pacific regions, talk about various areas of VSD occlusions. And the second session will be an interesting debate. It's a debate involving interventionists and surgeons about VSD occlusions. And we'll have hopefully an exciting discussion as well from all the panelists and also the participants either online or in the conference hall. So let's see if we are ready. Okay, so there seems to be, we still need a bit of time for the Taiwan team, so maybe I'll ask Warren to introduce the first speaker.
Thank you, Robin, and once again, thanks for the AP Cash organizing committee allow me to be virtually together with all of you. Such a pleasure and honor. Also, very honored to introduce my old friend, Supapan Roymani from Prince Concord University. She will give a talk on the outcome 1 year subarterial VSD device closure. So please, Supa, the stage is yours.
Yes, thank you. Good morning. Thanks, Robin and AP Cash for having me in this meeting. This study was done by our fellow Dr. Nantawan and was accepted and under processing of publishing in the Congenital Heart Disease about 1 year outcome of the outlet VSD closure comparing with the surgical closure. And as we know that in Thailand and also in Asian country, we have the high incidence of this type of the VSD and the spontaneous closure. We know that it is extremely rare. And we also have the limited study of the transcatheter closure in this type of the VSD, especially in the term of the aortic valve injury after the transcatheter closure. So our study is to evaluate the feasibility and early outcome of the transcatheter closure in selected case and comparing with the conventional open heart surgery. This is a retrospective study. We have the 104 patients and from two centers, the Prince of Songkla University and the Queen Sirikit National Institute of Child Health from Oregon. And we done by the 2012 to 2020. And the patient will have the evidence of the left heart enlargement or have the onset of the aortic valve collapse or aortic regurgitation was indicated to do the VSD closure in subarterial type. And we chosen to do the transcatheter closure if the patient is big enough and the VSD from the RV axis is no more than 6 millimeter and the irreversible prolapse or aortic severity is less than mine. And of course, there were no malalignment of the outlet septum. About the 54 patients were excluded due to they have the other associated lesion and have the minimal shunt and lost follow-up and have the spontaneous closure. For the procedure, it is what done as the same as the another type of the VSD, except we have the 5 sample view for the echocardiography.
18.
And
This
we
is
use
20.
and use the
Small size.
and also the RAO cranial for do the angiogram
This is 18 French.
or
20.
basic profile of the
This
VSD.
is. Okay.
We cross the hole by using the catheter. And we also do in both anti-gate and retrograde approach. And as you see here, this is a subarterial VSD. We measure the diameter from the LV and also from the RV. And in the multiple view, the short axis view, and also we do measure in the angiogram from the RAO cranial and also for the stiff LAO. The RAO will best profile for this type of the VSD rather than the LAO. And for the device selection, after we do the measurement in the echo and also the angiogram, we select the device as same as the LV size or plus 0.5 to 2 millimeter larger than the RV size. And of course, this type, we use a software device. In the first era, we use the PFM in most of the patients. After that, when the other device available, we use the LifeTech, we use the ADO2, we use the Piccolo, we use the Cora MF, and some of the patients, we need to use the Empressor one as well. This is the patient character. As we see that the transcatheter closure have the median weight and also the age is significantly higher than those in the surgical group, and also the size and the LV index were significantly larger in the surgery in the transcatheter. The size is larger in the surgical group rather than in the transcatheter group. This is the demographic data of the patient in the transcatheter group. As you see here in this column, prior to the procedure, about 1/3 of the patient have the pre-existing of the aortic valve prolapse. and about 32% have the less than mild severity of the aortic regurgitation in the transcatheter group, and 28% in the surgical group. And we use the ADO2 near 80% in most of the case, and we have used the antigrade around half of the patients. We have to, for patient have to change for the second device. The patient number 8, we need to change from the 6-4 to 4-4 because of they have the left ventricular outflow tract obstruction, which is abolished after we change to the smaller device. In the patient number 9, because of the last VSD, we have to change from the ADO2 to ADO1 10-8, and the residual shunt was disappear. For the patient number 23, we have to change from the PFM coil to the ADO2 because PFM coil have the unstable position of the device. And for the last patient, because this is a small baby, we need to change from the MFO because they have the right and left ventricular outflow tract obstruction. We have to change to the Piccolo 5-2, which is abolish the problem of the outflow tract obstruction. This is an example after we put the various of device for closure, the PFM coil, the ADO2 morphology, the Piccolo, and the Kona MFO. And all the patients have the successful device closure. Either we do the antegrade or retrograde approach. And this is the results of our patient. The efficacy of the transcatheter treatment is comparable to the surgery. In our study, also the number of the residual shunt in the transcatheter group was slightly higher than in the surgery group, both immediate and 1 year follow-up, but this difference did not reach the statistical significance. We estimate that because in the surgical group, the residual shunt can be better controlled in all directions during the surgical closure because the surgeon can suturing the superior rim of VSD through the base of the pulmonic valve, while when we implant for the device, the device is spreading to the defect, but is lost superior rim control during the cardiac cycle. And moreover, with the dynamic aortic valve movement, it may delay device endothelialization in this location. And because we need to use the soft device, which have no occlusion material inside, that's why it may have the problem of the residual shunt is high. And this is the aortic regurgitation severity immediately and 12 months after the treatment. There were not significant difference between the groups, and furthermore, the problem of the new onset or worsening of the aortic regurgitation was not significant difference between two groups. However, I want to make a note that there were a new onset of the aortic regurgitation during the follow-up period in few patients. In the transcatheter group, around 16%, and in the surgical group, around 12%, which is no statistical difference. All the patients have no pre-existing of the aortic valve prolapse before, suggesting us that aortic progression in this kind of the VSD needs to close monitoring even if the shunt is abolished. There were no other complications, the 0 degree of the heart block and the neo-tricuspid regurgitation. And I want to emphasize, if we want to close the kind of the defect, you have to medicalize the measurement and also have the appropriate device and site selection as we suggest before, and we need the device other design to have the inclusion material inside to better occlusion. And I want to emphasize in this type of the VSD, AR progression still have to be monitored even the chance is abolished. And I would recommend that we should early closure if the patient less than 4 years and before the aortic valve deformity. In my conclusion, in this era, although this is the early phase of the transcatheter outlet VSD closure, we propose that in the patient, if the weight is more than 15 kg and have the defect diameter less than 6 millimeter and have the less than trivial or my aortic prolapse or trivial aortic regurgitation, the transcatheter closure is feasible and safe when we comparable to the surgery in the short-term period. Thank you very much.
Well, thank you very much indeed. Very comprehensive review. Robin, I'm not sure whether we have time for discussion or we should move to Jokul.
Yes, I received signal that we can move to National Taiwan University, so we'll leave the Q&A at the end of the session. Thank you very much. So just a reminder to the participant online, you can always tap in any questions to the Q&A function, and the moderators will look at the questions and announce it during the sessions. So without further ado, I'd like to pass the session to Professor Joko Wang at National Taiwan University. Morning, Joko.
Can you hear me?
Yes, we can hear you now,
Okay.
nice and clear.
Okay. So we have transcatheter valve implantation this morning, this session, this patient. I would like to introduce our team, Professor Lin Min Tai and Professor Jing An Chen, and two young fellow here, and Mr. Han Jackson, who come here from Korea to assist us. And I would like to congratulate the Korean people for the win of the soccer yesterday. So can we start the presentation? Dr. Chen, introducing this case.
Thank you.
I'm going to introduce the first case. It's a 27-year-old male was diagnosed as repaired TOF and severe pulmonary regurgitation. The patient has a history of TOF and he received total correction at 1 year, 10 months old. However, residual mild pulmonary stenosis and severe pulmonary regurgitation was noted at follow-up. He was presented with progressive dyspnea on exertion for 1 year. The physical examination showed a grade 2 diastolic murmur at left upper sternal border. This is the chest X-ray. It shows a cardiomegaly. It is the electrocardiogram. It shows sinus reason with right bundle branch block. The QRS duration is about 140 milliseconds. This is the MRI. It showed the right ventricular dilatation, and the RV ejection fraction is about 20%. The pulmonary regurgitation fraction is more than 50%. This is the heart echo. It shows a mild to moderate residual pulmonary stenosis and severe residual pulmonary regurgitation. Then we perform the balloon sizing for this patient. This is angiography. It shows moderate pulmonary regurgitation. Then we use the sizing balloon for balloon sizing. The annulus is about 25 millimeter, and the waist diameter is about 21 by 20 millimeter. There was no coronary artery compression. This is a case summary. It's a 27-year-old male with repaired TOF and severe pulmonary regurgitation. Exercise intolerance and significant RV systolic function was noted. Therefore, transcatheter pulmonary valve implantation was indicated. Thanks for your attention.
Thank you. Thank you. So, Joko, would you mind if we start a bit of discussion before you proceed with your case?
Sure. Would you mind that we have the video of the MPA angio first and balloon sizing, and after that, you can discuss. Okay?
Absolutely.
That's
Great.
good.
Okay.
Please
Can we
proceed.
show the PA angio? Yes. There severe PR, and also can we show the balloon sizing while RV angio? The balloons, yes. This balloon sizing, there's no endocrine flow when the balloon was fully inflated. So we measure the waist. It's about the narrowest part, about 21.5 millimeter, and yeah, and 23. And we have in the last previous angio, we have also do the coronary artery interrogation test. There's no compression to coronary artery. So because for this live demo, I choose a pasta valve, one size larger than I usually use. I choose 28, and the length is 38. So you may go to the discussion.
Thank you. So I'd like to open discussion to the panel. So I think one of the important thing that I'd like to ask is, there is a bit of residual pulmonary stenosis in this patient, albeit it's not very significant. And there's a very nice ways, a choke point here we see on the testing balloon. So for these type of cases, does the panelist think that will decide on the intervention differently as compared with those with absolutely no residual stenosis at all? Would you do a balloon angioplasty or balloon valvuloplasty before actually implanting the valve? So Warren.
Yeah, Robin and Joku, a very nice case. May I start with maybe discussing with Joku a bit? Joku, so indication for this particular case is because of the RV dysfunction, right? And the severe pulmonary regurgitation.
Yeah.
Yeah, so if I recognize from your publication, maybe you also use the NT-proBNP to follow up the patient like this, right?
Yeah, right.
And how about NT-proBNP in this particular case?
I think it's normal for BNP.
The BNP level, the 46.
It's normal.
It's normal.
Pro
Okay.
BNP.
Thank you, sir. Well, just thinking that about the indication, and yeah, do agree that I think this case is feasible for valve implantation, and looks as if we have two ways, you know, approximately distally, but the ways that demonstrating here is a little bit distal. Yeah, do agree that you know, pulse star should be
because the outflow tract is a little bit dynamic, contractile. So I choose one size more than I usually do, and the gradient is 10 millimeter.
Okay.
Mercury.
Yeah. So Robin, if there's no gradient, I think we don't need to abolish the waist. Unless you have the gradient, which to me more than 30, that rings the bell that we need to do something. And of course, we need to use maybe less compliant balloon to interrogate that waist, whether it's you know, strong enough to hold the valve, especially if we use an expandable valve. So that's all for me so far. Thank you.
Yes, I agree. So any...
And yeah, from point of my view, I agree with Dr. Professor Wang and Dr. Warakan's opinion. And the pulse valve radial pulse is greater than this sizing balloon. So there's mild stenosis in this patient. So pulse valve can be implanted well at the narrowest area safely. I think so.
Maybe question to you. You may use 28 or 26.
Oh yeah.
Yes,
so,
that's my question
yeah,
too.
right. So because the narrowest area around 22. So if there is 26 millimeter pulse valve, I'll proceed 26 also. 26 will be enough for this patient.
Yeah, I agree. And so could you start to load the valve, the Jackson? Okay.
Okay. So yeah, before the loading, I want to show you first valve shortly. So maybe you can see the valve.
That's great.
Yeah. So our valve is a self-expandable type, and many doctors already know. So we made porcine pericardium, and we using two 19 stent woven texture type. Yeah. So yeah, softer than laser cutting device. So we already preparing the valve washing and delivery system checking. So right now I will go to the valve loading.
Okay. Can you just educate the audience, because some of us may not be very familiar with this. So how long is the washing time for this particular valve?
Yeah, our valve is recommend at least 6 minutes. So that means it's needed to 3 ball. Each ball needed to 2 minutes. So at least 6 minutes is required for washing.
Okay,
So you
please
want to introduce the delivery system?
Okay.
yeah, please carry on.
Okay. So this is our delivery system. So I will introducing shortly. So yeah, here is the tapered tip, and this part will be loading the valve. And this part is very important for, we call the hook block. We using this one for valve loading, and when during the deployment, the preventing the jumping out the valve. And this part is outer sheath, the covering the valve portion. And this is the sheath. And this white one is hemostat sheath for stop bleeding in femoral vein. And this is our delivery system. So we have 2 steps for deployment. First step is turn the knob clockwise, and final step is using the slider. So maybe during procedure, you can see more clearly. Okay. And so for valve loading, we need to this pusher for preventing the kinking this part. So now I'm starting to loading. The most important thing is the valve direction. So we must checking the valve direction is manually using the water and checking direction and insert inside of a crimper. And first step is close a little bit. And insert delivery system and start close. And during this time, we must hanging the hook. For safety procedure, we need to at least 2 hook hanging. So after finish, so close, must checking by hand.
Sorry, Joko, can you show us the side where the audience can see the valve, because we're only seeing the side of the crimper. That's great, thank you. A bit more. Yes, thank you.
Okay. A bit more zoom also, please, if you could.
Zoom here, please.
Zoom, yeah,
Yep,
to
that'd be
the to the hook. Thank you.
Okay.
We want to see the anchoring mechanism.
Yes.
Can we
So
zoom in
there
a
is-
little bit?
Yeah, zoom a little bit here.
Perhaps not digital zoom, but by camera, please.
Yeah.
Thanks.
Yeah, yeah.
That's better.
Now, Jackson, if you can show the hook, connect to the,
Okay.
maybe use a needle or something like that, because we couldn't see it drop.
Okay. So maybe you can see this.
There, okay.
Yeah.
That's great.
So yeah. So
Thanks.
we need to at least 2 hook hanging in the hook block like this. So I think right now we have 3 hook. So one here and another one here and another one here. So in the past we using the string for more squeezing, but right now we using this kind of forceps for gripping and push and checking. Yeah, so right now, everything inside of the outer sheath. After that, we must checking manually. So right now, everything is inside, so a little bit open. And yeah, grip same part and pushing the same power. And push inside. Okay. After that, most important thing is we don't need to too much press. Just a gentle push, both sides is enough. So right now is finish the loading.
Check.
Yeah. So
3 hooks.
yeah. So we have 3 hooks right now. So after the loading, we must checking the damage of delivery system and hook, how many hook hanging. Yeah, and also there is some gap or not. So just a little bit gap is no problem, but if you have a big gap, we need to insert more. Okay. So right now it's ready. So final, we need to flushing again. So de-airing inside. Okay. Okay. So now it's
Jackson,
ready.
sorry, remind us again the length of the valve. 38.
38.
Okay.
Yes.
So Joku, with that length, do we need to measure the length from the angio in order to make sure that the valve stay in place when we deploy the valve?
Then the angel. Now Now.
Okay.
Now we have a pigtail in the PA and then the quiz wire anchoring the distal right pulmonary artery. Then we now advance the sheath. We already dilated the wound. Okay. 后面
So
the
Joko,
wire.
are you using any large sheaths like Gore dry seal, or you just go?
No, just the sheath provided by the company is enough. It's very easy.
Can you remind the audience what's the size of the sheath for this delivery system?
Size is 18.
18 French.
Is the 20? Okay, it's 20.
20 French.
Yes. Be careful when you advancing the delivery sheet. You have to hold the wire.
Can you show
we see
angio
the
as well?
flow,
Because
please?
we're only seeing your hands.
Yeah,
那个
OK, sorry.
秀
Angel
病人的 angel，
刚刚录的那一段。
不，再看现在 Floro。
OK
现在的 Floro 修到香港去。
OK.
Can we have a very quick discussion, Joko, why you choose the right pulmonary artery? I know for venous ped, many a time they would choose left pulmonary artery as the standard. For me, when I put in, say, PD valve, I'll choose the right. Is there any particular reason why you choose the right pulmonary artery rather than the left in this particular case?
Yeah, because we usually pass the valve usually advance from the right pulmonary artery because of the tension is not the valve is not so stiff, so right pulmonary artery is okay. Better, I think for me is better than left pulmonary, and because I'll show you how it's very easy to advance the sheath because the wire is very stiff, and the sheath is also is soft. It's very good, easy to advance from RA, RV to PA. So I advance very quick.
Yes, I can see that it's very slick movement.
Just a quick share with you guys.
So we want to make the angio now.
原来4格的，回到原来的4格。
Just a quick share with you. If there is no proximal RPA stenosis, most of the time right pulmonary artery deployment is more coaxially aligned to the MPA. So
Yeah,
even
right.
venous P at the moment, I think we prefer to go to the right pulmonary artery if possible too, Robin.
Great. Yes, I agree. So the alignment is a lot better because we started off with PD valve implanting via the left pulmonary artery where we find a lot of alignment issues. So we switched to right pulmonary artery as the standard nowadays.
So I'm now going to make a pulmonary angio.
Great, go ahead.
I think maybe we got to pull a little bit back.
Yeah, so what do others think? I agree that I think it's a bit more distal than what we want to be.
Yeah.
Yes, maybe 5 or 10 millimeter deep distal part. Yeah.
Okay. So I'm going to inflate the distal flare. Okay. So turning the knob.
Show
Can you
us the
show
angio
the
too.
angio as well?
Okay, the angio also.
Can you make the live screen bigger for us?
Yeah, I have a live screen now.
Could it be bigger than that, please?
Can you see the live screen? Okay, stop. We got take the angio now.
Okay. So what do others think? I think from the lateral, I think it's a bit more retracted.
Yeah, right.
Proximally.
But I think it's okay. Still, we can deploy the valve here now. So.
Mm-hmm.
Yes, yeah, I agree. Yeah.
Okay. Okay, then we go to final deployment with a lever here. Okay. So. Okay.
Pull back the slider.
So what do you think?
Yeah, it expanded very well, and can you still the wire is too much tension to alveolar anterior part?
Okay.
So can you reduce the wire tone and check
Yeah,
hook block detachment?
Yeah. There's some hook still there.
Yeah,
So
so
we.
yeah. So if you reduce the wire tone, hook will detach it well. And can you magnify the fluoroscopy? From here we can see clearly the hook
really?
and.
Can you just make the fluoroscopy screen bigger? Oh, that's a cine. Right.
Okay.
So, Jibium, how can we be sure that we have all the hooks taken off?
Yeah,
it seems that still one hook is still hooked on, right?
Yeah, right. Still, because of the wires still have too much tension in the alveolar anterior part. In the case, the left side of hook is okay. Yeah, that's it. Yeah.
Okay, so we are pretty sure now.
Yeah. Right. And so the hook has radioactive markers. The hook and the pressure sent to the same plane. We should think the still one hook is attached there.
Right. So I think what you're trying to say is that the wire bias from the very stiff wire actually causes the hook to be still hooked on just now.
Right.
And I saw that we have lost wire position, but yep, we managed to remove the.
Because wire position, because the hook attached on the valve very tight, so we lose the wire.
Yes.
It's so that you can see the whole delivery system jump. Okay.
So, I'd like to ask the panelists. So, in this sort of situation, when we lost the wire completely, what would you do? With, I think what Joko did was very neat and brave. I would be worried to pull the carrot out. What would others do? Would you try to wire with something like a Terumo Advantage, where you have a soft tip and a stiffer shank, or you just pull this out?
If the distal, the nose cone is still distal to the valve, I probably will exchange to the softer wire and leave the wire in the MPA or the RPA if possible, and then just remove the nose cone. That I may do.
Usually insert thermal wire also in my case.
Okay, so because we have a lot of experience when the hook is still attaching on the valve, I lose the wire.
Yes.
I lose the wire. Then the loader, the carrot, and the hook will leave the valve. So I would like to make an angio now.
Sure.
But Robin, in this particular case, I think it's very less likely for a valve to migrate because the wedge is very
tight.
visible. Hopefully it should be okay. But yes, as you are aware, we may considering that.
Because I enlarge the valve a little bit, then I usually so because of light demo, I don't want to problem, so I oversize a little bit.
But Joko, in retrospect, you think 26 should be okay too, right?
26, I think I is okay for this case. But 28 is safer.
So with that, you in terms of the oversizing, any issue on the valve function?
No, we have some experience about the valve. Initially, this is the self-expandable valve, and after we deploy, there was some minor PR. If we oversize too much, then with time, the PR will getting less and almost no paravalvular leak. So I'm going to make an angio now.
Okay. Go ahead.
I think it's in good position. So Gabian, what do you think? It's good enough, or we should deploy more distal?
It's enough, very good position. Grip to where the sinus level also, very good.
Right. Do you think from the lateral, is there a bit of paravalvular forward flow, or is it just filling the sinuses?
Sinus, the sinus basava of the pulmonary valve. I think I don't care about the paravalvular leak because it will disappear in almost all cases within 2 or 3 months.
Okay. Joko, also back to the point of oversizing. Do you mind measuring on this angiogram the waist of the valve?
Okay. Anyone measure for us?
So I'm not sure how others are doing it, whether there's any experience in the so-called oversizing and the relationship of the final diameter to the degree of valve dysfunction. So what's the size? I can't see it very clearly on the screen.
I guess it will be 24. So that was still 21, only 21, the narrowest part.
Okay, so that's 25% smaller than the intended size.
Right.
Warrican,
Yeah, Robin, maybe question to Joku. Where is the valve is staying? I mean, in this particular case, it's at the marker or in the middle at the waist. I'm not quite sure. So that's one question. The second question, whether is it possible to get the image, something like, I'm not sure, maybe echo, just to see the valve function and the PR if possible, or I'm not sure if you can go beyond the valve to get the angio, but
Yeah,
probably
no
not.
problem.
Just echo. Thank you.
I think echo will be better.
Yes.
Because sometimes we try to advance the pigtail. Sometimes there's some problem.
Yeah,
Let me check.
probably echo is better and safer.
Yeah.
So from there, from RV, if we want to see angiography via using Termo and then go to MPA angiography, you can do that.
Okay. So I think any comment from the panelists?
Is it
Hello,
possible?
Professor Wang.
Yes, Professor Wang. Thank you.
Yeah. Thank you for your excellent demonstration. So I have a question for if you are larger device, relatively larger, should we worry about the coronary artery compression?
No. We have done the interrogation first in the previous balloon sizing, maybe 6 months ago.
Okay.
So that's also another question that I'd like to ask. So the last time when we saw the balloon interrogation, there was a significant waste, probably at the previous annulus or some fibrotic area. So that waste was not completely open. But now we have implanted a valve, a self-expandable valve. I know from Gibium that the pressure is probably just 1 to 2 ATM in terms of the valve radial force. But the waste seems to be eliminated quite a fair bit. So would that be some issues when you say you interrogate the coronaries? So the balloon didn't open up completely, but the valve did. So that's is that a bit of concern?
Important question. The first radial pulse is between the Diagen balloon and tie-shock balloon. Tie-shock balloon usually 1 or 1.5 ATM, the large size. So for the precise coronary compression test, we are doing tie-shock balloon interaction test. So if tie-shock balloon compress the coronary artery, sometimes we stop the procedure. And also the pulse valve is actually knitted wire backbone, woven texture. So compress during the contraction of the RBOT, move together according to the main pulmonary artery contraction. So not fixed valve. So I think the borderline case actually the pulse valve do not compress the coronary artery. So I mean, this is the more how can I say, flexible than the balloon expanded valve, not the compressed coronary artery.
Right. Dr. Chow, you have a question? Sorry, your mic.
Okay, sorry.
Right.
Yes, thank you, Professor Wang. It's a very nice case. Just actually follow on the questions of the waste raised by Robin. So, what do you think about, because when you have the raised there, because most of the time when the patient have TOF, they do not really have that kind of waste in alveolar tract morphology. So, with that affecting your decision on the size and as well as your position of sort of the valve implantation, because when you have a waist there, it's a very nice waist. So therefore, it will, to a certain extent, I think it may provide you a kind of something like a landing zone, a guide to a landing zone that you can put on, as well as the guiding with size. But if there's no kind of no waist at all, like most of the TOF patients, so would that affect your consideration in terms of the size and the implantation of the valve?
Now I'm showing you the precordial echo, but this man is very obese, so the echo window is poor. But you can see we can barely see the there's minimum PR and good with no pressure gradient and good forward flow. That's what we can see.
Okay. Dr. Chow, would you mind repeating your question to Professor Wang? Your mic, please, PC.
Yeah.
Thank you.
Yeah. So thanks, Professor Wang. So my question is about the waist. Previously already mentioned by Robin. So there was a waist in this patient, but in general, for most 2F patients, they do not have this kind of waist in terms of the alveolar tract morphology. So with that affecting your decision on choosing the size of the valve as well as the implantation, because to a certain extent the waist may provide you a kind of landing zone, but as mentioned, not many patients indeed do not have this kind of the waist in alveolar tract morphology.
Yes, if the waist narrowing is significant, maybe we need to put the stent in first, or balloon dilate the waist to make it more. But in this case, the waist is produced by so-called, we use a patch to, when the surgeon uses a patch to avoid significant PR, we call it monocusp. And I think the waist is produced by suturing the monocusp. So I think the waist actually is made by the surgeon, not the really the stenosis in the pulmonary. So I think the waist is now, even though the waist now in the valve, but I think the valve function is still okay. And I don't care too much oversight. Usually I choose the 3 to 4 more than the narrow waist, the valve size. And the length depends on the MPM morphology. If MPM length is good enough, I do choose 38. If the MPM morphology very short, I choose the shorter version. So you can see there's some PR now from the screen.
Yes, we can see that.
Yeah, but I think the PR will getting less day by day.
Yeah, I think from some of our experience as well, the valve does have some more expansion after implantation. I think Joe Kuo has mentioned this in another webinar earlier on. So the valve actually gets slightly bigger a while after implantation. So I think in terms of the oversizing, I think the pulsar valve design is very slick and it's compact, and it doesn't have a very huge flare, unlike many of the other valves. So oversizing seems to be less of a problem from my very limited experience in these live cases and stuff. Yes, Warwick.
Yeah, maybe question to Ki Byung. In retrospect, in this particular case, will you choose the Amplatzer stepwise rather than Lunderquist? So that's the question to you, because you normally saying that go to the right, better to use Lunderquist, and go to the left, better to use the Amplatzer, right?
Yeah, right. Yeah. So the Amplatzer step wire is more softer than Lunderquist wire. So when we use Amplatzer wire to right pulmonary artery, resistant to introduce catheter. So, but in the left pulmonary artery, Amplatzer is enough, and also easier to detach hook block from there. So in this case, we can use a left via pulmonary artery position. In the case, I want to use Amplatzer wire in the case.
I see. And how about Joe Kuo? I want to hear your opinion too about the wire option, like Lunderquist as well in retrospect, because we have difficulty on detaching the hook with the valve. In retrospect, is it better if we use the Amplatzer step wire instead?
No, actually, I have no experience about the Amplatzer in pasta valve, and I think probably if the Amplatzer wire may cause less hook sticking on the valve. But I think the Dunderquist is, I think we have every time we can, no, not much problem with Dunderquist. So I don't want to change our guide wire.
Sure, I think in experienced hands like Professor Wang, it's always okay. So in the interest of time, we have 2 questions from Dr. Pang and also Jenan. So Dr. Pang first.
Okay, thank you. Dr. Wang, congratulations for the wonderful lab case. I still have 2 suggestions for your consideration. Firstly, maybe we should insert the catheter to the main pulmonary artery and perform the angiography and measure the gradient by the catheter.
Okay.
That's better than echo gradients. And the second is that even if we perform the balloon testing to make sure whether we have any compress on the coronary artery, but the stent is totally different from the balloon. So to make sure the safe of the coronary artery, sometimes we have to perform the coronary artery angiography. Thank you.
Okay, because
for your
of the
consideration. Yeah, thank you.
Yeah, because the case we have the coronary artery compression test before, so I don't think there's much problem with the oversize. The valve may compress the coronary artery, and regarding the pulmonary angio, sometimes in majority of the time I will do it, but today because the pigtail catheter, I forgot to advance to the main pulmonary artery after we implant the valve. So I think next time I show the MPA angio. Most of the time we have MPA angio after that, but this time because of my concern is that because of when now we advance the pigtail, we need to use a wire. Sometimes the wire will pass the unwanted area, but sometimes may have difficulty. If we advance the pigtail, maybe there's some touch with the unwanted touch with the pulmonary valve. So I think we skip it. So if I have the chance again, I do the pulmonary angio.
Right, thank you. So one last question from Jenning.
Hi, Professor Wang. Thank you for excellent demonstration. I have a simple question. What is the follow-up planning for the relative larger device? Is there any difference from the regular normal? Will you repeat the CAS or CT for the follow-up during the follow-up? Thank you.
No, I will not repeat the surgery. At most, I will repeat the MRI 6 months later. It's required by our insurance company. And probably 1 or 2 years later, I'll do a CT to see the morphology of the valve and the pulmonary arteries.
Great. Thank you very much. So in the interest of time, let's give a round of applause to Professor Wang and his team. Thank you very much. Great case, very slick. And so we have to move on because Professor Wang needs to move on to the next case. So we'll see you in a bit of time. And now we're going to the rest of the lectures. So
okay.
Thank you very much, Joko. Thank you. We'll see you in a bit. So if the audience or the panelists have any further questions to Professor Wang, you can always ask him because he's going to rejoin us later with another lecture. So without further ado, may I pass on to Dr. P.C. Chow to introduce the next speaker.
Yes, thank you, Robin. Okay, it's my pleasure to introduce Dr. Xianbing Pan, who is the Vice President of Fuwai Hospital of China, as well as National Center of Cardiovascular.
30 seconds.
And so he is a hybrid cardiac physician holding
I need 30 minutes.
surgery and percutaneous procedure license. He has invented percutaneous and non-thoracoscopic procedure, which is a novel procedures of the intervention that led him to win the WHO Innovation Award in 2022. So he has made a lot of contribution in terms of cardiac interventions, and he has been elected as a foreign expert of several academic association in the SDS, ACC, and ESC. So without further ado, I would like to ask Dr. Pan to give us a talk entitled as Role of Biodegradable VSD Occluders. Dr. Pan, please.
Thank you. Okay, ladies and gentlemen, good morning. I'm Dr. Xiang Bin from the Chinese National Center for Cardiovascular Disease and Fuai Hospital. Today, my topic of my presentation is the role of biodegradable VSD occluders. As we all know, the transcatheter closure or VSD has been widely carried out in many countries, but no occluder has been approved by FDA for polymembranous VSD. Of all adverse factors, AV block seem to play the most important role. As for the mechanism, it's believed that the complexion from the mental stems is the main cause. So aside from the AV block, there are also several potential impacts from the mental occlusion device, like mental residue, tissue ablation, and so on. This unfavorable factor limited the application of transcatheter VSD closure technique. And on the other hand, the progress of the material science has promoted the research and development of absorbable materials, and its successful applications in absorbable stents and surgical sutures has further promoted the research and development of absorbable occluders. There were many absorbable devices designed and experienced in the past decades, but most of them failed to meet the market. The dilemma of the dilemma of absorbable device development was incomplete absorption led to new complication. Since the absorbable material is invisible under radiation and the traditional procedure can only implant occluder under fluoroscopy guidance, the mental markers need to be added to the absorbable occluder to locate it under fluoroscopy, and mental markers may fall off and cause embolism after the absorbable pulp is degraded. To break this dilemma, we successfully use echo to take the place of fluoroscopy in percutaneous procedures and solve the key problem of visible during the procedure. Compared with fluoroscopy guidance procedure, the echo guide procedures has advantage of protect patients, protect doctors, save cost, and suitable for promotion. Avoiding the iatrogenic radiation exposure can protect our patients while also protect medical staff. Besides, the echo machine is more accessible and economically than large DSA equipment, which can significantly reduce the healthcare cost and treat more patients in developing areas. And echo can show the absorbable material very clear. So that's the key advantage in the absorbable occluder development. So based on the echo guide procedure, a fully degradable VSD occluder have get the approval from the Chinese FDA in this year. The flake wall of the new occluder is made of PDO, and the flow blocking membranes was made of PLA. The degradable materials was continued to degrade 6 to 12 months after implantation, and the degradation speed was matched reach the tissue growth rate. And we also have a special delivery system. There is a special design latch to hold the device to keep it stable until release. A total of 108 patients was enrolled to perform a clinical trial to test the safety and effectiveness of the new device. And we have recruit 108 patients, and half of them received a new occluder, and another group received a mental occluder as the control. The occlusion success rate was both 100% and 12 months after operation. There are no 3-degree AV block in each group, and comparing 24 months ECG results between the two groups, the instant or sustained conduction block was lower in the bioabsorbable occluder group, which confirmed the safety of the new device. The new onset mild aortic regurgitation was observed in both groups, and there is no new onset aortic valve regurgitation, and the tricuspid valve regurgitation showed no significant difference between the two groups. There is a compared demonstration between the two groups. This is 1 month after the procedure. We can see here is the test group. We use the absorbable occluder. This is the control group. That's the mental occluder. In 1 month, you can find the absorbable occluder, just like the mental occluder. And 3 months later, the absorbable occluder is still here, just like the mental. And in 6 months, the absorbable occluder is begin to degrade. So the intensity is lower than the mental group. In 12 months, we still can find the occluder. It haven't degraded completely. But we also have finished the 24 months follow-up. Absorbable completely. Here is the mental occluder, nothing changed. There is a very short video to show the whole procedure. For the clinical trial, because it's the first fully completely absorbable occluder, so the ethics committee asked me to perform the transventricular procedure, because we can have a safety line. Even if the occluder fall off, we can find the occluder. But now we have get approval from the Chinese FDA, so we have performed the transfemoral procedure for our patients, because the delivery system is almost same, just the length is different. So this patient, we get the wire past the VSD, and then we advance the delivery system. It's a 7 or 8 French. This is the very short delivery system. And then we have to go a little quickly. Yeah, we put back the wire and the inner core. Yeah, you can find the delivery sheet in the left ventricle. And then we advance the occluder. Here we are relieving the left side of the occluder and put back. Because the elastic of the absorbable material is poorer than the mental material, so we have a locker and with the help of the shaping line to help our occluder remove to the normal double disc shape. Yeah, just like this. And there is no aortic valve regurgitation, no Lechton sham. And then we release the occluder and close the minimal incision. Beside the VSD occluder, now we are carrying out the clinical trial for observable ASD and PFO occluder. And we are making plan, maybe next year we will perform the clinical trial for PDA observable occluder. We also hope that our colleague can join us together. Thank you.
Thank you, Dr. Pan. In the interest of time, we may allow one quick question, and then we'll move on to the next talk, and we'll wrap up all the questions at the end of the session. So any quick questions from the panel or from the floor in the conference hall? If not, may I ask one question? So yeah. Excellent development, and congratulate you, Dr. Pan. You have made very, very great advances in the field. So since this occluder is not actually visible under fluoroscopy, have you had any situation that you actually need a rescue situation where, say, for example, the occluder embolizes or is not in the perfect position? So what's the rescue plan for these sort of patients?
Because you mean that the Lechton sham?
No, for example, if there is embolization of the device, so the device moves, and if there anything, is there any bailout plan, any backup plan? Is it go straight to surgery or?
We have. Yeah, thank you for your question. That question is very important. So that's also the reason why in the clinical trial, we have to perform the transventricular procedure, because we have additional safe line. Fortunately, in all the patients, we don't use the safe lines, no occluder follow-up. But the key problem is that now we have get the approval from the FDA, well, Chinese FDA. If the occluder go away, it's difficult to fight it. We also have the backup. Firstly, we can perform the angiography. You also can perform the angiography because the occluder will be occlude some artery or pulmonary artery or aortic artery. With the help of angiography, you can find the occluder, and you also can catch the occluder and put it back. And you also can help your surgeon to find the occluder.
Right. I think there will be a lot of follow-up questions on that, but in the interest of time, let's move on, and then we'll get back to the Q&A at the end of the session. So is Professor Wang ready? Yes. So
okay.
Yep. So I would be introducing Professor Wang, who actually needs no introduction at all. So Professor Wang just shared with us a very interesting case and his team slickly performed the case. So Professor Wang is currently the Chief of Pediatric Cardiology Section and works in National Taiwan University Hospital, Taipei, Taiwan. And he's also the CEO of the Taiwan Cardiac Children's Foundation. He was appointed as a professor of pediatrics at NTU from 2000. He was also appointed as president of Taiwan Society of Pediatric Cardiology from 2012 to 2018. All of us would know that Professor Wang is a very experienced interventional pediatric cardiologist. Without further ado, may I ask Professor Wang to deliver this talk on challenging cases in VSD occlusion. Professor Wang, please.
Thank you, Robin, for your kind introduction. I'm going to talk about challenging case of VSD occlusion. And what about the challenging case of VSD occlusion? Maybe involve a large defect, small child, complex anatomy, outer extension with aortic valve prolapse, myelin VSD, and multiple exits. And definition of large defect depends on yourself. And diameter measured from various image plan 3D will be helpful. And usually with the select device is 2 millimeter larger than largest defect diameter. And you have to be careful with the valve. When you're dealing with large defect, you can enter VSD from RV side. It will be need more save a lot of time and no need to establish every loop. And large VSD in low body weight, you need to have hybrid. Sorry. The crossing VSD from RV is quite easy in large VSD. You see? Okay, then you avoid the need for AB loop. Then large VSD like this, 30-year-old man, QPQS 2.1. Sorry. And you see the no aortic rim on TE. So I choose a LabTech device because at the time there was no MFO. So you can see the shunt, and after that, complete occlusion and no AR. And 3D is quite helpful. You can see the defect is beneath the valve. And after that, device occlusion. And if the patient body weight is limited, very low, like 4 kilogram, you can have hybrid procedure. Then this is a case of our hybrid procedure. We use a 81. And when body weight more than 6 kilometers is preferred for transcatheter tactic. And now I use MFO in almost every case. In case of severe heart failure, you have to send the patient to surgery or use hybrid procedure. This is a case of 18 months old, under anti-failure treatment, body weight 8.6, hemodynamic like this is this pulmonary hypertension and QPQS more than 3. You can see the how large is it. It's really a precordia. Then we show the angel. It's really big. The measurement is 7.8 and on TEE is 7.5. So I choose 10.8. MFO. And I advance 6 branches from IBC to RA to IBCI, RV, cross VSD to PA. Then I use a wire, then advance the sheath. You can see. Then I start to deploy the device. Okay, now you can see after device deployment and check the echo. It's in good position. So I can almost no residual shunt and no severe TR. So I detach the device, and this 1 month follow-up, you can see the device sitting there quite well without TR and AR. This is another example. 2.8 year VSD size is big. So I choose 8 hot R Sarah. And the breathe size is about 6.7. So I plus only 1.3. And this is the echo. And after that, trivial AR, but I don't care because the AR is very tiny. And dealing with multiple acid usually occur in muscular trabecular type. But in Oriental population, we have perimarin type more, and one entry hole with multiple acid. And in my experience one device is adequate for perimembranous type with multiple acid in most cases. And I just choose the largest acid, enter and close it. And this is an example. You can see the multiple acid on TE. This is another example with 2 acid. The angio, you can see the 2 acid. And I close with embed ball. And the result is like this. Very good. And with complex anatomy, like tricuspid septal defect involvement, make a large aneurysm or moderate LV to I shunt, and sometimes associated with F-stent anomaly. This is case associated with F-stent anomaly and heart failure. So I choose to close it with a transcatheter technique. And you can see almost complete closure with AD01. And if the patient has other extension with RCC prolapse, then if the prolapse too much severe with herniation more than 50%, we exclude the case for surgery. And we need to use a soft device, MFO or ADO2 or a symmetric double disc device. But in Taiwan, we don't have a symmetric double disc device. And this is the case we use retrograde deployment of the MFO. And this is, you can see the prolapse is significant. You see here, and with my AR. And I deployed the ADO2, and there's some residual. But this is post-angio, post-deployment angio. In most patients with outlet extension deployment, after deployment, the residual shunt is quite common. With malalignment type, I will exclude the case for catheter closure because of this not our transcatheter cases because of embolization and technical very difficult. And recently, why I changed my mind to use embed ball because it's very soft and very easy to use. So I would like to send some take-home message. Challenge case for VSD, closure large, low body weight, outlet extension with LT valve prolapse, complex anatomy, and don't touch the malalignment type. And some index patient with index extension, you have to be very careful about that. And you have to evaluate the VSD anatomy carefully with various imaging tools and device selection depends on yourself. But I like MFO because soft and easy, and even you oversize a little bit, that rarely have heart block, and you always have surgeon standby. So thank you very much for providing me this opportunity to present the talk. Thank you.
Thank you, Professor Wang, for your word of wisdom. It's always great to learn from experts like you. So the session is now open for Q&A. So the panel or the audience from the floor and audience online can ask questions. Yes, Jibium, please start.
Yes, thank you for wonderful lectures from all of three doctors. I want to ask the subarterial venous closure. So is anybody of this room has experienced that LV disc has adhesion to the aortic valve leaflet? So because it's my worst long-term concern for subarterial VSD closure in the long term. So the short-term result, I think it will be good, but the long-term outcome, more than 10, 20 years, if we close in the early period, if there's adhesion to the disc and the leaflet, it's my long-term concern for this patient group.
Right, so anyone would like to take the challenge in terms of long-term results for subarterial VSD occlusions?
Yeah, perhaps Supra first, huh?
Yep.
Actually, we don't see it long enough to answer you this question, but I think now Tin have the long-term study. I think maybe like the 8 year that he follow up this kind of patient. So it was also some patient have get improved because the device supports for the collapse and less degree of the regurgitation. And also they have some patient that also have the problem of the more aortic regurgitation after he follow up for the 8 years. So for this question, I think we don't know yet. Yeah, I can answer you, but I think for this kind of patient, we need to do, if we want to do the VSD closure, I think we need to do early, as I mentioned that we need to do before like the 4 years old from the Dr. Cheng's study, and we need to do before the aortic valve deformity occur. Yeah, this is my opinion. Thank you.
Thank you, Supra.
Thank you.
Well, Robin, just to follow up on that, Supra's answer. I think what Supra mentioned on her talk is quite interesting, because even surgically, correct the subpulmonary VSD, but still having AR progression, and that's warns us a bit that surgery only is not prevent AR progression. So that's the thing. Maybe I would ask Xiang Bing to comment on that too. But yeah, so I think it's very difficult to say. But if it's lasts for, I don't know, 3 or 4 years, and then we have no problem on that AR, I think at least we can say something. I think Tin mentioned that AR is not progressing in most of the cases of his, but again, we don't have the data yet.
Right. Okay, so we have 2 questions online for Professor Wang. So actually asking the same question. What's your consideration in closing VSD for patients with associated Epstein anomaly? Is there any special consideration?
Because of heart failure, the patient has some degree of heart failure and failure to thrive. So I think because the VSD are moderate size, so the LV is a little bit large. So I think maybe we can close the VSD first and see what happens after that. But the patient is still, it's thriving well, and there's no new severe TR. So I think we keep on follow up this patient, like a usual type of Epstein anomaly.
Right, so a follow-up on that. So technically, is there any additional consideration as compared with other usual type of perimembranous VSDs?
It's more difficult. So I use setup first, but fail. So I think AD01 will be better, because AD01, the left disc is a little bit larger than the waist. So AD01 for this Epstein will be with a higher success rate. So I think in that case, I use AD01.
Okay, thank you. I think the difficult part with these, with tricuspid valve abnormality associated with VSD, is that we don't know how the valve would actually behave when we put in the device.
Right.
So the additional monitoring with echo is actually very important.
Yes.
Right, so Professor Jennings Wang has a question.
Yeah, I have a question for the Super or Professor Wang. Congratulations for your great excellent talk. But my question is, during these kinds of submaterial type VSD, do you have, you mentioned several cases, small cases, small residual shunt. Is still the heart murmur still audible? And how do you think? Do you think is it possible to deploy the second device in this kind of cases? My second question is, do you think using the earlier interventions recommended? So with using your recommendation, will you lower the body weight limitation to maybe 10 or 12 kilograms? Thank you.
Yes, thank you very much. For the residual shunt, we don't hear any murmur at all. It's just a foamy appearance through the device. Yeah, and as I didn't tell you the definition for the the shunt is 1 or 2 millimeter, and for the trivial residual shunt is less than 1 millimeter. So it's just the echo finding, which is not clinically significant. I think I see the paper from Dr. Juku as well, that he used the ADO2 and the residual shunt is around 40, but it's just a small, which is not clinically significant. But, we have to show. And for the second question, I forgot. Can you repeat it again?
Yeah, my question, I think I would like to ask, in some case, what kind do you think to deploy the second device, another device to occlude the residual shunt? And the second question is the body weight limitation. Do you think is smaller, maybe is okay for the procedure? Okay, thank you.
Yeah. If I have another hole, which is the first device is not covered, I will put the device, or if I hear the murmur, significantly, I will try to put another device. So for the body weight, I think nowadays we try to maybe do the transcatheter closure, like Dr. Juku said, maybe 6 kg also feasible to do the transcatheter closure. Yeah. Because this study is in my first year preliminary. So at that time we want to do in the small children. Yeah, but nowadays we do in the small children. Yeah.
Okay. So in the interest of time, one last question from the online question. So I think again open to all. Is there any consideration or long-term outcome in terms of the high frequency of residual shunt after closure of VSD by MFO, like say, for example, endocarditis prophylaxis? So it's open to the panel. Anyone has any idea?
To me, if I didn't heard any murmur, I just give the aspirin, but I don't think it will risk for the endocarditis if we don't hear the murmur. Yeah, but of course, in the first 6 months, if they need to do the dental procedure, I will prescribe for the antibiotic before dental procedure.
Yes, Warren.
Yeah, in my experience, MFO, I mean residual shunt is not that significant to me compared to ADO1 or other type of device. I think residual shunt is very minimal. I don't know, maybe I'm wrong, but I'm not much considering on that.
Okay, so in the interest of time, I have to draw this session to a close. I'd like to thank all the speakers, panelists, and operators in the live cases for this very excellent sessions.